Hi, Mike Gibson, joined by my good friend and colleague, Bela Merkely. Welcome, Bela, and talk to us a little bit about the Budapest CRT study.
Hi, Bela Merkely, good to see you. So let me shortly introduce the rationale of the study. Approximately more than 1 million conventional pacemakers or ICDs are implanted each year worldwide. Nearly 30% of these patients develop left ventricular systolic dysfunction due to intraventricular dyssynchrony induced by right ventricular pacing, leading to a relatively high incidence of heart failure hospitalization and associated adverse clinical outcomes. In HFrEF patients with a pacemaker or ICD, the potential benefits of an upgrade to CRT, where an extra LV lead is implanted to the coronary sinus side branch, have not yet been established. Due to the lack of data from large randomized controlled trials, the class and level of recommendation for CRT upgrade have been modified several times over the past decades in ESC and US guidelines, showing an unmet need for more robust evidence. The aim, Budapest CRT Upgrade is the first trial to compare the efficacy and safety of a CRT upgrade compared to ICD alone in HFrEF patient with pacemaker or ICD and intermittent or permanent right ventricular pacing. The trial enrolled heart failure patients with reduced ejection fraction, less than or equal to 35%, who had received a pacemaker or ICD at least 6 months previously, had heart failure symptoms, New York Heart Association class 2 to 4A, a wide pace QRS complex, wider than or equal to 150 milliseconds, a high burden of right ventricular pacing, more than or equal to 20%, and were treated with optimal medical therapy. Patients were excluded if they were eligible for CRT according to the current guidelines, or had severe right ventricular dilatation, severe valvular heart disease, and severe renal impairment, or had survived an acute myocardial infarction or coronary revascularization in the previous 3 months. Patients were randomized to receive a CRT-D upgrade or ICD in a 3:2 ratio. The primary outcome was the composite of heart failure hospitalization, all-cause mortality, or less than 15% reduction of left ventricle and diastolic volume. Secondary outcomes included a composite of heart failure hospitalization and all-cause mortality and echocardiographic response. Safety outcomes were also assessed. Analyses were conducted according to the intention to treat principle. A total of 360 patients were enrolled from 17 sites in 7 countries and randomized to receive a CRT-D 215 cases or an ICD 145 cases. The mean age was 72.8 years and 11.1% were women. During a median of 12.4 months, the primary outcome occurred in 58 out of 179 patients in the CRT-D arm, which is 32.4%, and 101 out of 128 in the ICD arm, which is 78.9%. The adjusted odds ratio, 0.11, 95% confidence interval, 0.06 to 0.19, the p-value less than 0.001. The beneficial effect of the CRT-D upgrade was homogeneous across all pre-specified subgroup: age, right ventricular pacing, burden, left ventricular ejection fraction, atrial fibrillation or flutter history of ischemic events, diabetes, New York Heart Association class, NT-proBNP, GFR, or BMI. Regarding secondary endpoints, in the composite of heart failure hospitalization and all-cause mortality, CRT-D showed significant benefit compared to ICD, with an adjusted hazard ratio of 0.28, p-value less than 0.001. Left ventricular morphological and functional response, according to echocardiography, also favored CRT-D compared to ICD, with a difference at 12 months in LV and diastolic volume of minus 39 milliliter, p-value less than 0.001, and a difference at 12 months in left ventricular ejection fraction of 9.60, p-value 0.001. The rate of serious adverse events was about the half in the CRT-D arm compared with the ICD arm. CRT group 30.2% versus ICD group 60%. The incidence of procedure or device-related complication was similar between the two arms. CRT-D group 12.3% versus ICD group 7.8%. The occurrence of major ventricular arrhythmias was substantially lower in the CRT-D arm, 1 out of 215 patients, or 0.5%, compared to the ICD arm, 21 out of 145 patients, 14.5%. Let me conclude. Upgrade to cardiac resynchronization therapy with a defibrillator reduces morbidity and mortality and improves left ventricular reverse remodeling compared to an implantable cardioverter defibrillator in patients with heart failure and reduced ejection fraction and intermittent or permanent right ventricular pacing. These findings support performing a CRT upgrade in this patient population. HFrEF patients with a pacemaker or ICD should be strictly followed in clinical practice, and in those with intermittent or permanent right ventricular pacing. A CRT upgrade should be performed immediately without postponing the procedure to a later date to avoid or reduce the risk of further adverse events such as mortality, heart failure hospitalization, or left ventricular remodeling.
Oh, thank you. That was amazing. Were there any subgroups that stood out as having particular benefit?
It was a very homogeneous result. So all pre-specified subgroup has the same results, which was presented during the presentation. So it was similar in different age groups, in different right ventricular pacing burden from 20 to 100, left ventricular ejection fraction, presence of atrial fibrillation or flutter, history of ischemic events, diabetes, New York Heart class, NT-proBNP, GFR, and BMI. And very interestingly, more than 50% of the patient had permanent atrial fibrillation. So in that specific group, CRT alone is able to significantly reduce the risk for hospitalization and mortality, and of course, for remodeling. And that's the very first results, actually, in the everyday clinical practice that strongly support that even the patient with atrial fibrillation can have benefit for an implantation of CRT device.
And Bella, when you get rid of the remodeling endpoint, when you look at death and rehospitalization alone, those hard endpoints, what did you see there?
So if you look at the echocardiographic data, there was a clear evidence for reducing the end systolic volume and end diastolic volume. It was highly significant. And at the same time, the left ventricular ejection fraction increased by 10%. And this is also very much interesting that the rate of life-threatening ventricular arrhythmias, such as ventricular tachycardia or ventricular fibrillation, were significantly lower in the CRTD group. And the difference was remarkable. 1 out of 215 patients versus 21 out of 145, 0.5% versus 14.5%. That means the reverse remodeling can significantly decrease the risk of life-threatening arrhythmias in that patient population.
But when you look at death and rehospitalization, did you see a difference there?
Absolutely. So the major difference was found, of course, in hospitalization and in reverse remodeling. We did not find any significant difference in mortality. It was a tendentious difference, but this study was not powered to demonstrate mortality differences.
Great. Well, Bella, thank you. Very well done. Thanks for sharing the results, and thanks for all of you for listening in here from ESC 2023.
Thank you very much for the opportunity.